simply asking them a question, would this work for you, is pretty important, and often we don't do that, and we come up with what we think are great ideas and great interventions, and wonder why nobody's coming forward and taking advantage of our great idea. So it's so critical to have that voice at the table, and there's some strong groups, and I know in this area there's groups forming, and so it's really important to support these organizations, and I'm advocating strongly for the new provincial response, that there's actual funding directed straight for these organizations and don't have to funnel through health authorities and different things that make it very difficult for these organizations to exist. So I think that having them at the table and intricately involved in how we're putting out these programs is important. A lot of the prevention sites right now are run by peers, so it's extremely important, and they serve an extremely important process there. The other thing that I think is extremely important is getting people safer drugs. So at the end of the day, we're this far into all these deaths. If we recognize that the problem is fentanyl, carfentanil, and a toxic drug supply, we have to find ways to give people alternatives. It's not acceptable, it's both naive and ineffective to say, be careful, don't use these drugs. I mean, we know that is not going to work, and that basically is a message that we're giving people. We're giving them few alternatives. Buy these drugs that we think could kill you. If you have the opportunity, why don't you go to an overdose prevention site so if you overdose, somebody can give you naloxone. That is not going to work very well for most people. So we need to give people the opportunity to access the drugs that they need. And the obvious model is the crosstown model in Vancouver, where people go 3 times a day to inject heroin or hydromorphone. But this is extremely expensive, many rules and regulations, and I don't think it's scalable. There's 20,000 overdose calls last year. We're not going to get 20,000 people into a prescription heroin program. So we need to come up with more scalable, urgent responses to this. And so I have a proposal in now to Health Canada that would give out hydromorphone pills to people. An 8 milligram hydromorphone pill is 32 cents. A vial of hydromorphone liquid is about $25. So these are very cheap, readily available. They can be ground up and filtered properly and quite safely. People have been using them for a long time, and so to create programs where people can pick these things up, I think is, to me, the practical response to this. And there's all kinds of concerns about people diverting them and getting them out on the street. To be honest with you, under this environment, I don't think that's a terrible thing. If you're selling your dilaudid to somebody instead of them taking fentanyl, it's probably not a bad thing. That's not a popular way to get this program going, though. So I need to convince people that we can reduce diversion by regulating this. So maybe some people would have to use on site initially, but to get people who are hidden and just need access to safer drugs, we need to have some kind of low barrier program where maybe daily they go somewhere, pick up a few pills and take them with them. And so this is something that I've been pushing, and I'm waiting to hear back from Health Canada soon. If it's approved, then it's a very scalable thing. And in a place like Nelson, you could open up a storefront tomorrow and start this. So because it's not, dilaudid pills are, just prescription cheap pills. We don't have to do any special importation of heroin or anything. This is pretty standard stuff. There's doctors out there prescribing them all the time. So it's not a huge leap as far as regulation goes. It's just a huge leap in people's understanding about how we're going to deal with this. And if we sell it, well, I'm not bringing you on this because I don't know if you all agree with me yet, but if I sell it, and some of you can sell it, as a way that we sell all harm reduction. It's a way to engage people. So I'm not saying that people have to be on this for their lives, but in this current situation, to reach out to people, get them engaged, and move them on to Suboxone, methadone, abstinence, whatever your goal is fine. But as a starting point and in a crisis situation, I think that is a pretty practical way to move forward. So I'm hoping, and I've talked to the ministry about this, so And I think I got them kind of thinking on that side. So even if Health Canada doesn't approve it, I'm hopeful that we'll get some money to start something up in the from the provincial government. And there's an announcement tomorrow that I'm going back for, and that'll be my message that we need to really think hard about allowing people access to drugs that won't kill them is kind of my shtick on that. So safer drugs, I think, is really important. The third thing was pain management. So again, it ties quite closely into the last one. So what are we doing about people with chronic pain problems and chronic trauma problems? And so having doctors just say we're not giving out narcotics, having emergency departments tell all the physicians do not prescribe this, having people labeled when they come into the emergency department, they're drug seekers, to make sure you don't give them any drugs. I mean, this kind of attitude just has to change. I mean, we cannot be squeezing people and giving them the message that, oh, I have a drug here that you'd really like, but I can't give that to you. Why don't you go back there and some dealer has some fentanyl for you? So that's basically what we're telling people, and we know that they're going to be using it somehow. And so as a medical intervention, it just seems much less cruel to me than to allow people to get what they need right now, and we'll worry about the how we're dealing with them and integrating them while they're alive. And so to tell people that we can't give you this and they die of an overdose, and things have changed dramatically. So I think we got away with that forever, because people could go to the emergency department, not get what they wanted, and go buy heroin or get some dillies on the street or something, and they would not die of an overdose. We put them in bad positions. They'd have to steal and scrounge and find the drug. But now that same person could easily die. Like, there's a high chance that they won't come back to the emergency department and try that again because they won't be around. So we're really in a totally different world, I think, and we need to be talking to people about the harms of these illegal synthetic drugs versus the harms of prescription drugs. And the long-term harms of prescription drugs we've seen, lead to all kinds of problems for people, but for the most part, they don't kill people. And so we need to differentiate those two things, and we can't be having doctors' offices with these posters up there. We can't give you anything that you want or need. Having said that, I think we really need other alternatives. So it's not good, we need to fund other alternative ways for people to deal with their pain, whether it's trauma support or physiotherapy or acupuncture, all these things that are technically out there and could be helpful to people. We set up tremendous barriers. There's no funding for that. We can't, a poor person can't access these things. So if we're not going to if we really don't want to give people more opiates and we think this intervention would work, that intervention would work, then we have to fund it and give people actual opportunity to do it. It's not good enough to say, I think physio would be good for you, go find physio. I mean, people will not find physio. So the fourth thing we've talked about is supervised consumption sites. I've talked about that already. I think they're an extremely important way to connect with people. The data is just overwhelming in favor of these things, so we really need to scale them up. Having said that, with a fentanyl epidemic, we could put a supervised injection site on every corner of every street in the province, and we'd still be having a lot of people die, because a lot of people are kind of hidden. They don't really access our harm reduction services much. The last thing they want to do is go to a place where they're outing themselves and injecting drugs and opiates. So we need to provide alternatives for a lot of the people that are dying. But for those people who are open to coming to supervised injection sites, clearly that's something we should be offering people across the province. Addiction treatment, and again, having all kinds of ways that we view addiction treatment, and that is not getting into a hospital bed in a mental health facility. For the most part, people need supportive housing, they need a community to work with, they need counseling and trauma support, these kind of models of how we really deal with treatment. And I think the most successful models have been in a housing environment where people can be housed and have a supportive environment for people around them. So that to me is addiction treatment. How we align this with law enforcement is critical. I think it's very important that law enforcement is at the table and discussing all this, because they have the power to undermine a lot of the stuff that we want to do. But with all due respect to the police in the audience, the health teams have to be the senior partners at these tables, not the junior partners. So we can't be fishing around for little things that we can do because of law enforcement. Law enforcement should be facilitating these ideas and helping us to create safer environments for people. So I think traditionally health has been the junior partner of this, and we need to be the senior partner. And there's way more of us here than police, so already we're the senior partners. But
or so you think.
Yeah. Just by numbers. It would take 3 of us to take this guy down, because he's quite big.
Oh no, I'm a bleeder.
So you know, we have to. This is something that came out. Police were at our meeting, but we need to be really at the table together and not be really need to go for the common goal right now is to stop people from dying. And many of the things that we need to do rely on a change in the way we approach people who use drugs. I'm certainly a decrim person. We're moving in that direction right now, but hopefully most police officers have come to the point that arresting people for having drugs on them and drug paraphernalia is not helpful. I put words in your mouth, sorry. The whole war on drugs clearly comes out strongly, and there's a group of people working on how we can decrim things. A lot of people have read and visited Portugal, so that's a model that we're trying to pursue, where they have decriminalized drug possession, but they've moved in with a lot of services for people. So if we stopped arresting people today, I don't think we'd be in a better position. For individuals, they might not be in jail as much, but we need to step in with health interventions and social interventions that will be able to support people. And so it's not just decriminalization in Portugal that worked. It was putting the funding and resources to supporting people and reintegration programs, employment programs, even very simple things. Portugal went to employers and said, we will pay for this person to work, we'll pay their salary for a year. Imagine if you took people who just want a job and said that we'll give you a full salary, you'll work for this person, and the response was amazing. People you wouldn't think could show up for a job every day, all of a sudden showed up for a job every day. So and got reintegrated, and so there's really practical things that Portugal did that really reduced the number of people needing treatment and really decreased the number of people using drugs. Obviously, supportive services. So, referring back to my initial slide that we need to have a comprehensive approach that can't be siloed. Clearly, there's a role for all these upstream things. So we know we're not paying enough attention to youth, and we know that there's kids in trouble that we're not offering them the supports they need. So these upstream things are also extremely important, taking care of people's mental health and providing other support services. That's just I think that's a picture from Shiway or something. But there's lots of things that we can do upstream to prevent this stuff. I think that in an emergency situation, there's certain things we have to do to stop people dying. Helping youth right now is not going to translate into less overdose deaths next year, but these things are obviously part of our comprehensive approach. Countering stigma, so a lot of us are involved in that. The way we treat people who use drugs is horrible. The things I still read in newspapers are shocking, the way society still feels about this, so we all have a role to really reduce stigma. I don't think, though, that we're going to go far reducing stigma in a criminalized environment. So if you think of something that would stigmatize people, it's making it illegal. So as long as there's legal implications to drug use, criminal implications to drug use, stigma is an uphill battle. We've basically made a decision as society, if you use drugs, you're doing an illegal activity or a criminal, belong in jail. And it's pretty hard to, convince the general public that, no, actually it's not that bad, we should destigmatize it, treat people humanely and stuff. Well, we're not treating people humanely, we're putting them in jail. So I think the stigma campaigns and the criminalization are closely linked, and we probably will have until we deal with that. If we could decriminalize things in the province, stigma would evaporate a lot. I mean, that would be a huge push to reducing stigma. So I don't know how successful we'll be one without the other. And then what started the whole thing, and as far as our emergency response, is still really dealing with good data. So we really, these rooms are extremely important to be able to come to a collaborative table to make sure that we're getting the information out there and continuing awareness. We are at a bit of a tipping point with public awareness, I think. We've been into this for almost 2 years, and the general public could start losing interest in this. And we need to continue to remind people that we're still in the middle of a huge crisis, and and that data to support what we're talking about is extremely important. I think our response is, there's 3 main barriers to our response right now, all of which I've talked to. The first is our toxic drug supply. So that's just a picture of what, the strength of these different drugs. So imagine trying to get a little packet of heroin together, mixing with some caffeine or other white powder. There's a lot of latitude there. If you use fentanyl, you can't make too much of a mistake. If you're actually mixing carfentanil with a blender, you're not going to get it right very often. So our toxic drug supply is really something that we need to have a head-on response to. And as I discussed in some detail, I think we really need to offer people an alternative to taking these opiates, and that would be low-barrier prescription drugs. The other thing we touched upon is social services. Many of the issues that we're dealing with, again, are fixable. We don't need these kind of tent cities out there. People deserve options in housing, and so this is not cheap either. And I thought it was fascinating. A few months ago, the famous Balmoral Hotel was condemned in the downtown east side. The same day, the announcement was from the federal government that they were giving British Columbia $10 million to fight the opioid response. And it occurred to me that fixing up the Balmoral Hotel would cost way more than $10 million. And that would be like for 150 people to live in a decent place. So the whole housing strategy is tied closely into this. And this is not a cheap solution by any means, but giving people some stability and some housing and some income is extremely important, and we can't, that's one huge barrier that we still have. We can't just focus on getting people safe drugs and getting supervised injection sites if we're still allowing people to have no access to any supportive housing. And finally is criminalization. So I think that we really need to back off on that. As I say, spending resources, and we spend millions and millions of dollars intercepting drugs, and I think that's proven time and time again not to be an effective strategy, and that the whole emphasis needs to be on the demand side, not the supply side. And finally, I'd just like to acknowledge, as it was acknowledged at the beginning of this meeting, that this has a huge toll on communities, and talking to people who have literally lost their whole circle of friends in the last couple of years. I mean, imagine the devastation that has on people. And I think there's some efforts to recognize that, but not near enough. And I think it's up to us as a community to make sure that people are recognized in their death and what it means, and to support those communities. And often we leave it up to really grassroots community people with no resources to try to do something about that, and I think it's paramount that we, well, that worked out just perfectly. Paramount that we do that. So, yeah, so that's all I have to say. Thank you. lost track of time. What am I doing, Alex?
So it's 20 to 11. We have until 11 is what we, I thought we should use the time for questions.
Okay. Quite happy to do that.
Any compelling questions from the audience? Yes.
Sure. I was glad to hear you speak about having a prescription and approach and give people that, because I think most of fentanyl deaths are because it's an illegal product. They're dying because it's black market. But what I was wondering about is, well, we are a drug society. I mean, almost everyone here this morning was on caffeine, all right? And there's people that drink, etc. So why do I always find harm reduction? They'll support things like, you know, supervised injection sites and naloxone kits, but rarely they talk about legalizing and regulating all drugs. Because to me, that's the only way we can deal with this problem of deaths. I mean, we're always going to have a certain percentage of the community that has addiction problems, and we can help them. But I just find the harm reduction rarely comes out against drug prohibition, even though we know it doesn't work. It didn't work with alcohol, etc. And I would say most of these people would still be alive if they had a prescription or a legal dose of opiates. And the reason it was illegal in the first place was because of racism against the Chinese people. And it concerns me that we sort of sometimes focus on, you know, Main and Hastings, downtown east side. Yet I think the reason there's concern is because now it's white middle class kids and upper class kids that are taking some cocaine and somehow find out there's fentanyl in it and their friends die. And that's the only reason why I see a lot of caring now. And I think it's legitimate, because now it's not your drug user on the downtown east side. It's the college student. It's the, you know, and there's people that you think are respectable, upstanding citizens are also dying. It's not just people being on the street. That's my rant. So I was glad to hear you talking about prescription, but I just find that that's where harm reduction fails to me, because we need to look at a legal regulated market.
Yeah, your point about, I think we have to fight back a little bit in this narrative that people are dying, this weekend warrior kind of idea. That I don't think that's happening. The people that were surprised that are dying are people who have used for a long time, had a very secure source of getting their prescription opioids, and were using them and functioning. And all of a sudden we're telling them, well, actually you can't get that anymore, and they're having to go to illegal. So those are the people that are surprising us. And wow, how did they die? Well, they were functional opioid users for a long time, and this had a supply, and that we've disrupted that. So, and the call, I think, if you look at the actual numbers, I think of 1,000 people, there was maybe 20 that were 19 and under. So it's not a high school problem, and most of those 19 and under were kids that were already quite entrenched. So it might be useful as far as getting our message out there that this can happen to you, but in the reality, it's not. You know, getting naloxone into all our high schools will not make any difference. But I guess from a public perception point of view, getting the message out there, this is not just Main and Hastings, is potentially a bit useful.
Thanks for your talk. It was amazing. And I just wanted to ask a little bit around the proposal that you have to have down for the pill form of hydrogen.
Sure, I can't hear
Sorry,
that.
can you hear me?
Nope.
Thank you. Can you hear me now? Yeah. Okay. I wanted to ask a little bit about the proposal that you referenced to Health Canada for the pill form of hydrogen. Is there anything, so we're working on a proposal across the region for injectable, but is there anything that would stop physicians now from prescribing the pill form? Is that something that could be promoted if physicians are willing to do that?
it's really tricky. So there's been a message from the College of Physicians that you're being audited. So a lot of people who were supporting people long-term with higher doses of opiates have been sanctioned.
Yeah.
So there's a scare amongst all physicians that they shouldn't be doing that. It's, I think to get it going, we need some physicians to stand up and start doing that. I'm trying to position this as a public health initiative. We should be able to, like vaccines, or like if we needed to vaccinate everybody, we wouldn't send people to their doctor to get a prescription. We have a public health approach to this. I still haven't figured this out yet, and in our proposal, it is a more of a physician one-on-one thing that we do, but I want to try and break that down because physicians, because of all the legal issues with them, they don't want to be in the position where drugs that they prescribed go missing or are diverted, even though I don't think that's the end of the world, but that's their fear. And also if somebody takes a bottle and downs them and dies. So there's legal issues for physicians, even the most enlightened ones that are a little uncomfortable with this idea that I'd give very high doses of oral pills to somebody because they're kind of responsible. I think as public health, we have to take responsibility with that. And other models, nurses, pharmacists, and people could order in bulk. As a public health doctor, I could order like a bulk shipment of this stuff and then have ways to regulate it. That'd be the best way for me, but I'm still in conversations with the college. If the college tells me if I could come up with that model, they wouldn't care about it. It's not in their jurisdiction. They're just interested in the physician prescribing things. They don't really care about how I do it. So, I don't know, we could all break the law and just order a big barrel of Dilly 8s or something and start distributing them ourselves. But then we'd be drug dealers. But at least we'd be safe drug dealers. So that's a technicality. I think that there's a real move across the province to try to get these injectable programs going, and there's new kind of